AMP 2.0's second webinar on common ENT conditions seen in general OPD. This session will be presented by Dr. Queenie Elizabeth, and our moderator will be Dr. Tia Thomas. Dr. Queenie is from the batch 2016, and she has completed her rural bond from Gudlur Adivasi Hospital, Nilgiris, and hence has first-hand experience in dealing with common cases we see in our rural service. Dr. Tia Thomas is from the batch of 2014, and she has finished her post-graduation in ENT from Father Muller's Hospital and currently works as an SR in our ENT department in St. John's. I warmly welcome both of them to our bootcamp session. Also, a note to all the people logging in for the webinar, kindly keep your microphones off, especially when the presenters are speaking. But feel free to raise your hand in case of doubts, and you will be given a chance to ask your questions, or please also feel free to leave your questions in the chat box. Also, please remember that this is a friendly and no judgment zone. All the people attending these sessions are most likely your batchmates or someone who's going through the same rural bond service as you or who has already completed their rural bond service. So we all understand what you all are going through, and no question is a silly question. Please feel free to ask any doubts and feel comfortable to attempt to answer questions that have been asked during the session to make this session as interactive as possible. Now over to Dr. Queenie.
Hi, I'm Dr. Queenie Elizabeth Jacob, and the moderator for today is Dr. Tia Thomas. We'll be discussing on the basic rural rural ENT cases that are seen in the healthcare system. So the first case scenario is a 4-year-old male came with complaints of severe right ear pain and fussiness for the past 24 hours. He had a history of URTI 4 days back. On examination, you see that the child is conscious, cooperative, irritable, and has a fever of 101 degree Fahrenheit. So what do you think the diagnosis could be? On examination, these are the examination findings that are seen. The right ear tympanic membrane is bulged and congested. The left tympanic membrane is normal. Nose bilaterally, nasal cavity shows mucoid discharge, and oral cavity shows that the fascial pillars are congested. So the diagnosis is acute otitis media, and the management, these are the basic managements that are done. That is, you have to give them analgesics and antipyretics, that is tablet paracetamol at the dose of 10 to 15 mg per kg every 6th hourly. You can start them on antibiotics like amoxicillin, that is at 45 mg per kg per day. You give them as 2 divided doses. You have to treat the underlying URI. You also advise the mother to monitor for any worsening of symptoms such as increased pain, fever, or any change in the ear discharge. You also schedule a follow-up appointment in 2 to 3 days to reassess the child's condition and to consider further management, which may include referral to a higher center and if the AOM does not improve. And in AOM, because you have to note one thing very clearly, that you avoid eardrops as much as possible, because that can prevent the healing from happening in the children. Now let's come to the second case scenario. It's a 32-year-old male, and he's come with complaints of left ear discharge on and off since childhood, non-foul smelling, intermittent, and it's aggravated by upper respiratory tract infections and relieved by medications. On examination, you see that the right tympanic membrane is normal and the left tympanic membrane has a medium central perforation. Nose and the oral cavity is normal. So what do you think the diagnosis for this could be? Yeah, like Neetika said, the diagnosis is CSOM. So now the patients has recurrent episodes of the same thing. So the diagnosis is CSOM. Because there's no discharge mentioned, it's mostly a safe type, that is a tubotympanic type of disease. So now what we try to do is we gently clear the ear canal with a cotton tip. Like you can just to remove out the extra discharge, so that when you put the antibiotics, it's actually absorbed inside. The antibiotics of choice in case of a CSOM is ciprofloxacin eardrops, that's given as 3 drops Q6H for 10 to 14 days. And we can give the patient analgesics, but in case of CSOM, the patient usually does not have pain. So there's no need for giving analgesics like paracetamol. Now you have to give the patient few advices, like you have to tell the patient not to get the ear wet while taking bath. So you can just put a cotton cotton like bud in the ears while taking bath or something like that, and you schedule a follow-up appointment in 2 weeks to just assess if the patient's responding to the topical treatment. And if it's not, then you have to consider further management options, which include referral to a tertiary care center if the CSOM does not improve. So now there are some red flag signs that if you see in a patient with CSOM, you definitely have to refer the patient to a higher center. These include giddiness. If the patient has complaints of signs of raised ICP like headache, vomiting, blurred vision, if there are any signs of meningitis like fever, neck rigidity, facial palsy, now, in a diabetic, you have to be careful because the infection can get complicated in case of diabetes, and then they can present with pain. So, diabetic with a deep-seated ear pain is also a red sign, and then you have to refer these patients to a ENT specialist. So, in the case we discussed about a safe type, that is a tuber-tympanic type. Now, you always have to rule out an unsafe CSOM, that is the atticoantral disease. Like you can see in the image, there'll be granulations and cholesteatoma flakes that are present around and a polyp that's seen here. These patients usually come with complaints of foul smelling, scanty, blood tinged, or purulent tear discharge. And these usually are not completely relieved by medications. So whenever you see this, you have to be worried and refer the patient out. Now there are two other things. When you see through an otoscope and you see something like the first image, then it's mostly Candida albicans, that is creamy like material. And in the second one, you see a crumpled up appearance like a newspaper, crumpled up newspaper appearance. That's for Aspergillus niger. In both of these patients, also you should think about referring the patient to a higher center. These patients usually come with complaints of unilateral ear pain, ear fullness, itching, and they'd be from a humid climate. They might have history of instrumentation or overuse of antibiotic or steroid ear drops. So you start these patients on clotrimazole ear drops, 3 drops thrice a day for 7 days. And you also tell them the same dry ear precautions that they have to maintain while taking bath. And you have to regularly dry mop the ear under vision. That is, the patient has to come to you and you clean it under vision. Now there's another thing called otitis externa. These patients usually come with complaints of ear pain and fullness of the ears. They can have history of any instrumentation or they went swimming that's and water entered the ear, something like that. When you examine these patients will have tragal tenderness when you press here, and when you look, they'll have diffuse through the ear canal. You'll see that they have diffuse canal edema and there's erythema. Uh, for these patients, we generally prefer topical antibiotic drops, like same ciprofloxacin can be used for these patients. And you can also give them oral antibiotics like ciprofloxacin or azithromycin. Because these patients also have pain, we start them on analgesics. These patients have a lot of edema in the ear canal. To reduce the edema, we can ask them to put a ear you can put a wick in the ear canal that is coated with magnesium sulfate to just help reduce the edema. Similarly, like the previous patients, we tell them to keep a dry ear precautions and to regularly dry mop the ear under vision. Again, in these patients, there are some red flag signs that if you see, you need to refer the patient to a higher center. If the patient's diabetic or immunocompromised, you refer the patient off. If they have complaints of giddiness or any cranial nerve palsies or involvement, and if they have deep-seated ear pain, then you refer the patient to a higher center. Now there's a thing that is sudden sensory neural hearing loss. A patient comes with a history of sudden hearing loss. They give a clear-cut history that till yesterday they could hear and suddenly today they cannot hear. Then that's a sudden hearing loss. They can have oral fullness, tinnitus, or giddiness. That is, if it's there, you have to refer the patient to a higher center. Usually, when you do otoscopy for these patients, they'll have a normal otoscopy finding, and when you do the tuning fork tests will be suggestive of sensory neural hearing loss. You guys know that the sensory neural hearing loss through tuning fork is when the RNA is positive and the Weber's lateralized to the unaffected ear. So when these patients come, you start them on a short course of oral steroids, that is prednisolone, which is started at the dose of 1 mg per kg per day for 7 days, and a maximum of you can give up to is 60 mg per day. Do not exceed more than that, and you refer them off to a higher center. So the problem now is if you do not start treatment immediately, then there's a chance that the patient could have permanent hearing loss. So you have to explain the urgency to the situation to the patient and refer them off. This is another patient. This patient has come with complaints of foreign body in the ear. So you can see that they put in under vision, we're taking it out with the help of a forceps. Try to visualize where the where the foreign body is, and then take it out under visual guidance. This is another case where we've shown a insect. So now when there are insects, you can either take them out piece by piece, or you can take them out completely together. The problem with insects are, if they are live, they can cause damage to the ear canal. So what you can do, and I found is helpful, is you put lignocaine drops into the ear canal, keep it for 3 to 5 minutes, let the patient settle down, and then the lignocaine would cause the patient to uh, it'll numb that area. So the patient will have less pain, will be more cooperative when you manipulate, and even the insect will die off because of the lignocaine. So this helps solve your purpose. You can just use a long tooth, like the this image, the instrument in the image. You can just use it, hold it, and then remove it out very easily. Fine tip forceps. Now, when there are foreign bodies in the, sometimes patients come with foreign body in their ear for a longer period, like they had it for 3 to 4 days or something like that, then there could be presence of discharge. In that case, you start them on antibiotics. Similarly, in case of insects, you start the patient on topical antibiotics. Now, there are different types of foreign bodies. So if it's something like in the first image, that it's a round shape, like if it's a pea that you've put inside, it'll be difficult to hold the pea with the forceps. So in that case, you can use, see in the second image, the round tip. You, with that, you can manipulate it and try removing it. In other case, if it's irregular shape, then you can just hold it with the forceps, fine tip forceps, and just remove it out. The other thing that you need to consider in case of a organic material like pea is, if you put any liquid inside, then there are high possibility that the pea could swell up and increase the problem. So try not to put, try not putting any lignocaine or any other kind of fluid inside, because some people say you can just try syringing out the pea or something like that. But if it's an organic material, there's a high possibility it would swell up. So just see if it's organic or inorganic, and then decide your steps. You can, in case of smaller beads or toys, something that they put, you can even try syringing it out if it's not possible to remove with the help of a forceps. Now, another thing that patients generally regularly come to us is with cerumen impaction. Sometimes the patient come and the wax is very hard. In those cases, you tell the patient to put solivax eardrops. Let the, it's like a ceruminolytic, so they put it 3 drops thrice a day for 5 to 7 days, and then ask them to come back after 5 to 7 days. The wax would have become, it wouldn't be as solid as before, and then you can try syringing it out. So syringing is a very easy technique that you can use. You normally use normal saline or normal water at room temperature, at body temperature. You retract the pinna outwards, backwards, and upwards. So then the ear canal comes in a straight line, and then you syringe in posterior superior direction. You keep syringing for some time, and then the cerumen will easily come out. And at the end, you just dry the ear with cotton. Now, there are some contraindications of syringing. If they all, you know that the patient has a pre-existing perforation, you avoid syringing, because then the water could go into the middle ear. If they have any history of previous ear surgeries, any complaints of ear discharge or otitis externa, then you avoid doing syringing at any cost. Any doubts till now? Or is there something that you did not understand? Okay, then we'll move on to the next case scenario. Uh, uh, yes, no, yeah, Tia.
Sorry, my bad. You can go ahead.
Oh, Nathaniel, did you have a doubt?
Yeah, regarding otitis externa, I think you said oral antibiotics as well as topical. So do you go with both or do you just go with one?
Uh, I think maybe yes.
So depending on the severity of otitis externa, Nathaniel. So basically, if you're just seeing early canal edema, it's an early stage thing where just tragus sign is positive, history for 1 or 2 days, no profuse discharge, you can go with topical antibiotics. But if a patient's in severe pain, it's been more than 2 to 3 days, it started to become purulent, you can add an oral antibiotic as well. Good choices, like she said, would be amoxicillin and clavulanic acid, or even sometimes pseudomonas can be the positive agent. So ciprofloxacin is a good choice as well. 500 mg BD.
Do you decide on aggressive treatment based on how, like, in terms of immunocompromised or diabetic, do you go more aggressive or
Yes.
how?
So like we said, basically malignant otitis externa is something that we need to rule out, especially if the patient is diabetic and immunocompromised. If they come to you with severe pain, disturbing their sleep at night, any coexistent giddiness or facial palsy or cranial nerve palsy, then you can check for gag reflex, absent gag, facial palsy. All these things will point out that it's progressing towards malignant otitis externa. So in that case, patient will require IV antibiotics for 4 to 6 weeks and possible imaging as well. So in that case, better to refer. With regular fungal infections, otomycosis, you can start treatment on your own. You can start clotrimazole. However, that rarely we're seeing a lot more of fungal malignant otitis externa as well. So if it's not responding to treatment, and patient develops these warning signs, please refer.
Yeah, thank you.
Dr. Prithvi's asked efficacy between analgesic drops versus oral or syrup analgesics.
So basically, if the canal stone is very inflamed, then the efficacy of topical drops isn't much. It's better to give an oral analgesic because ear pain can be severely painful. In very few of the cases, this is topical drops alone enough.
So we'll come to the next case scenario. It's a 58-year-old male who's come with complaints of profuse bleeding from bilateral nasal cavities since the past half an hour, and it started spontaneously. His vitals are BP is 160/90. Bilateral nasal cavities show active bleed, and when you check the posterior pharyngeal wall, there's an active trickle. What do you think it is? Any answers? It's basically epistaxis. In epistaxis, there are some things that you need to make sure if the bleeding's from the anterior nasal cavity or from the posterior nasal cavity. If it's from the anterior nasal cavity, in case of children, there could be history of nose picking or some complaints of trauma. In those cases, in every patient, first thing that you ask them to do is you do a bidigital compression. That is, you press on the cartilaginous area for 10 minutes in Trotter's position. That's, you ask them to bend forward, head down, and you press it for 10 minutes and see. After 10 minutes, if the bleeding has stopped, it's good. If it has not stopped, then we need to think of something else. Now you saw that the patient had a BP of 160/90. So you also start them on a short-term libitalol, and it will take care of the hypertension. Hypertensive patients can also come with his complaints of spontaneous bleeds. If the bleeding has still not stopped, you can take cotton and soak it with adrenaline plus tranexamic acid and keep it in the ear. Keep it in the nose, and then just wait for some time and see if the bleeding has stopped. If after doing bidigital compression and putting cotton soaked with adrenaline and it's still bleeding, you have to consider doing anterior nasal packing. But you need to make sure that if anterior nasal packing is done, then the patient has to be admitted and needs antibiotic prophylaxis, that is IV antibiotics. We'll show you a video on how to do nasal packing. Nasal packing is started from the floor of the nose and then you keep layering it upwards. Because this patient came with complaints of bilateral nasal cavity bleeding, we'll pack both the noses. But you have to be very careful when you're packing both the noses because if the patient's unconscious, breathing becomes a problem.
Packing bilateral cavities, there's no problem with that. Main precautions that you take while packing is try to take a long ribbon gauze. 1 meter should be good. No, but if you use small pieces, there are chances that it can be retained as a foreign body. Try to lubricate the gauze with either medicated ointment or you can use paraffin. You can even add a bit of diclofenac jelly so it's not too painful. But you should ensure that the patient is on antibiotic cover after packing. And as long as there is a pack in the patient, it's better to keep the patient under observation with you. And regularly assess the patient for recurrent bleeding. Still, you can examine the posterior pharyngeal wall and see if there's any trickle. Once the bleeding has settled, then you can remove the pack under observation.
Now the immediate management, we have to find out the cause for the bleeding. It could be a URTI, any nasal trauma, or if there's a spur. In children, they could be there's a history of nose picking, or if there's some drying and local inflammation in the little's area. In all of these patients, you give them saline nasal drops also to keep the area moist. If the bleeding does not stop, there's another option of cauterizing with TCA. You also have to work up the patient if it's an older patient for hypertension. Check the hemoglobin, platelets, and coagulation workup, because if the bleeding, I mean the CBC or the platelet or coagulation profile is deranged and the patient needs admission or referral. The red flag signs in these patients would be persistent bleeding despite packing. If there's history of recurrent unilateral nasal bleed in young patients, that is, it could be JNA. Trauma with features suggestive of CSF leak, and if there's an altered CBC or coagulation profile. In these cases, you would prefer to refer a patient off to a higher center. Now we come to the next case. It's a 35-year-old female with complaints of facial pain, bilateral nasal obstruction, thick yellow nasal discharge for the past 10 days. On examination, in the nose, bilateral nasal cavities show thick mucopurulent discharge. There's bilateral maxillary tenderness, and oral cavity shows a posterior nasal drip. Both the ear canals are normal, tympanic membranes are normal. What do you think the diagnosis could be? Anybody would like to try? Dwani said it could be bacterial rhinosinusitis. That's correct. So now we need to know what the definition of rhinosinusitis is. Is the inflammation of the nose and the paranasal sinuses characterized by two or more symptoms, one of which should either be nasal blockage, obstruction, or congestion, or a nasal discharge. That could be anterior or posterior nasal drip, with or without facial pain or pressure, reduction or loss of smell. And endoscopic signs are not very, I mean, we can't check it in a Bond center, but according to the definition, it would be endoscopic signs of nasal polyps or mucopurulent discharge, primarily from middle meatus, and edema or mucosal obstruction, primarily in the middle meatus. And in the CT, you see mucosal changes within the osteomeatal complex or in the sinuses.
So basically, your endoscopic signs are part of the definition. Even your nasal examination findings will be contributory. If you see purulent nasal discharge, which is mucoid, and the overall nasal mucosa looks congested, that's enough for you to kind of pinpoint the sinusitis along with at least two of these symptoms. Nose block, anterior or posterior rhinorrhea. Posterior rhinorrhea being postnasal drip, with or without facial pain or pressure, and with or without nausea. It can help you differentiate it from other headache mimickers like migraine or tension type headaches or cluster headaches. These points are the ones you need to focus on to make sure it's actually sinusitis.
So now if there are two of these ARS symptoms, that is, one is nasal obstruction and the other is discolored discharge with or without facial pain, reduction or loss in smell, and for the past 10 days, then you look for the other things. That is, if there's fever, if there's double sickening, unilateral disease, severe pain, raised ESR or CRP, then in these cases, if it's present, then you refer these patients to the primary care. And in the primary care, you check for same symptoms. And in the primary care, if the symptoms have been more than 10 days, or if it's increased or increased after 5 days, in these patients, you can give them decongestants if it's been less than 10 days, intranasal corticosteroids, any saline sprays or rinses. In all of these patients, try to avoid antibiotics if its symptoms are less than 10 days. But if all of these, that is fever, unilateral disease, severe pain, none of these are present, then you just send the patient home with self-care. That is, you give them self-education, give them decongestants for less than 10 days, give them NSAIDs, paracetamol, zinc, vitamin C. You can consider saline sprays and rinses, and again, avoid antibiotics as much as possible. But if they've had more than 3 episodes of bacterial rhinosinusitis in the last 3 years, then you consider antibiotics. And if you see if it's improving in 10 days or not, if it does not improve, then you have to refer the patient up to a higher center. If the once a patient goes to a secondary or a tertiary center, you consider and test for differential diagnosis and treat accordingly. It could be a fungal ball, or if there's bacterial resistance, or if there's immunodeficiency, or non-sinus diagnosis like migraine. When patients come with complaints of pain, like facial pain, headache, similar symptoms, you need to differentiate if it's migraine or if it's rhinosinusitis or any other condition. Now, there are some red flag signs that if you see, you have to refer the patient to a higher center. That is, if they have periorbital edema or erythema, if there's a displaced globe, double vision, ophthalmoplegia, reduced visual acuity, severe headache, frontal swelling, signs of sepsis, signs of meningitis, or neurological symptoms, you immediately refer the patient to a higher center. So the medicines that we basically use are saline nasal drops, 3 drops thrice a day for 10 days. You give them decongestants, but you give them only for 5 to 7 days. If it's more than 7 days, then you ask them to stop. You give them 3 drops thrice a day. Then you can also put them on intranasal corticosteroids like fluticasone furoate nasal spray, 1 puff in each nostril once or twice a day. And if necessary, we start them on antibiotics, that is amoxicillin plus clavulanic acid, or any third generation cephalosporin, or any broad spectrum antibiotic should be useful. You can also start them on short term antihistamines. Now there's a emergency situation, that is mucormycosis. You might have seen during the COVID times, or any invasive fungal sinusitis. So in case you have a high index of suspicion, like that is in diabetic patients or immunocompromised patients, then they have come with complaints of headache, blurred vision, or double vision, or if there's any discoloration of the palate, facial numbness, loosening of teeth, then these patients have to be referred to a higher center for urgent nasal endoscopy and KOH mount to look for fungal elements and imaging. Next scenario. 5-year-old child has come with complaints of foul smelling unilateral nasal discharge for the last 2 days. On examination, there's a purulent nasal discharge in the left nasal cavity with a visualized greenish foreign body. So as you can see that this is a foreign body in the nose. Uh, you can watch the video to see how you can examine in case of a child. If the child is uncooperative, you can always try making the child sit on the mother's or father's lap and then trying and examining the child. And after
So
every
by default, try to take the foreign body out in a seated position, because especially in a nasal foreign body, there is a danger of pushing it behind. However, sometimes we have to modify our approach based on how cooperative the child is and how restless he is. Try to only remove foreign bodies which you can see and you can visualize, because there's always the danger of pushing it back into the airway. So the trick is to just go behind the foreign body and put it in front. In soft foreign bodies like chalk pieces or soft cotton, or some people take even foam pieces. Some children take foam and put it in their nose. That you can try to use a gentle suction. So in this position, you can see that the child's legs are locked between the mother's legs. Her arms are immobilized by the mother's arms, and the other arm is used to support the head. And one more thing you have to remember is the first attempt that you have is the best attempt, because after that the child is feeling the pain and is definitely not going to be cooperative. So don't hesitate to use all the measures possible to make the child still for your first attempt to be the best possible.
In the next scenario, it's a 28-year-old female who has come with complaints of fever, throat pain, and painful swallowing for the past 3 days. On examination, ear bilateral are normal. Nose, minimal watery discharge is seen in the bilateral nasal cavities. In the oral cavity, you see that the facial pillars are congested and the posterior pharyngeal wall is congested. In these patients, you know that this is pharyngitis. So in these patients, you will start them on analgesics because they will have painful swallowing. You can tell them to start salt water gargling and to review in 3 days if there is worsening. In all these patients, try to rule out reflux and allergic pharyngitis. So in treatment of pharyngitis, you have to see when like you have to decide when to start antibiotics. For that, you use a score called a center score. You look for fever, anterior cervical lymphadenopathy, tonsillar exudates, and absence of cough. Based on that, you give one score each. If the score is 4, you can start antibiotics immediately. If the score is 2 to 3, you just wait and watch. And if it's less than if it's less than 2, that is 0 or 1, you just have to wait because it might not be a bacterial infection and there's no need to start antibiotics in this case. Uh, you see patients coming in with tonsillitis all the time. So you need to understand when to start antibiotics and when not to start antibiotics. These are some images in which you should start antibiotics. Like the patient has follicular tonsillitis or membranous tonsillitis. In these patients, all of these cases, you should start the patient on antibiotics. You can consider hospitalization and IV antibiotics if the patients are unable to swallow anything orally. Send CBC, ESR, get a throat swab, and monitor the temperature regularly. These patients usually come with complaints of throat pain, dysphagia, not able to swallow properly. Now, there are some red flag signs that if you see, you have to refer the patient because it could be something other than tonsillitis. So, if the patients come with complaints of progressive difficulty in swallowing, hot potato voice, difficulty in breathing, and then when you look at the oral cavity, you see that there's a midline posterior pharyngeal bulge wall or a lateral pharyngeal wall pushing it medially. In these cases, you have to consider two scenarios, that it could be a retropharyngeal abscess or it could be a peritonsillar abscess. Both of these patients can worsen quickly and need to be referred to a higher center. Now, the other things that you have to worry about is also recurrent tonsillitis. Some patients have more than, there is a criteria, that is if they have more than 3 episodes in 1 year, more than 5 episodes in 2 years, more than 7 episodes in 3 years. In such cases, it's better to get a tonsillectomy done so they can be referred off to a higher center. If the patient also has complaints of obstructive sleep apnea like snoring, then these patients should also be referred to a higher center for further evaluation. And if it's just a unilateral tonsillar enlargement and you have a suspicion of malignancy, even in that case, you should refer the patient to a higher center. Any questions? This is basically most of the basic cases that are seen in the a rural setup. There are other things like giddiness that are seen in a rural setup, but it would go on for way too long, so we thought maybe we could do it later. Any questions?
So I think Samarth had previously asked about cheap and reasonable options that you can use, because not all centers have a scope. So there are free available otoscopes online. There are around 800. You can ask your centers to get them. Or even more useful are these pocket endoscopes, which are only 1,000. And you can always carry it with you, connect it to your phone, take a screenshot of an image if you have a doubt. And you can even use those in the nasal cavity as well. So that would help diagnose and treat a lot of ear, nose, and even throat conditions. So those are. It is someone that's safe to use. Even it is safe to use. They're not unsafe, but they may not last for very long. As far as what we've seen, we do have uh, ENT PGs and peripheral postings who use these. You can wipe these with Savlon or Sterilium twice after each use to maintain sterility, especially more contact time with the antiseptic agent if the ear is discharging, or the nose is discharging, especially. Uh, I know it's not ideal, but these are just alternatives for you in case you don't have all the required instruments. Pardon, I didn't see that. Uh, can the same be used for both ear and nose across different persons after sanitation? Yes, it is. So basically, ear, I think you're just going to introduce it after pulling the filler upper, backward, and outward. You're just going to introduce it just so that you can see the external ear cavity. You're not going to put it deep. So be careful that the outer part is cartilaginous. You can just introduce it there. Someone had asked the difference between pediatric and adult examination. It's pretty much the same. Adults, you pull it upward, backward, and outward. Pediatrics, you pull it downward, forward, and laterally. That's the only difference. Some of you also asked about common antibiotics that are used. So amoxicillin and clavulanate acid is the safest of the drug. In adults, you can use 500 mg of amoxicillin TID, 875 mg DB. So along with clavulanate, that would be 1 gram. And in pediatrics, you can use around 25 to 45 mg per kg per day, depending on the severity, reaching a maximum of 90 mg per day. Another good option in case of penicillin allergy are cefixime, cefpodoxime, other third generation fluorophorins. You can also consider doxycycline in adults for sinusitis and azithromycin as well. Common antihistamines that we use would probably be cetirizine. So less than 2 years, we try to avoid it unless absolutely necessary. It can cause a lot of sedation. But 2 to 5 years, you can use 2.5 mg once a day. And in 6 to 11 years, 5 mg once a day, adults 10 mg. Same goes with phenylephrine, which is a decongestant. So in sinusitis, you could give an antihistamine combination with the decongestant. That will actually help decrease the vasoconstriction and decrease the nasal stuffiness. So again, in children, the dose would be 2.5, 5, and 10. Easy to remember. 4 to 5 years, 6 to 11 years, and in adults. So oral decongestants are phenylephrine. That's a good option. Topical nasal decongestants are xylometazoline or oxymetazoline. Xylometazoline typically we use 0.1%. And like Queenie mentioned very correctly, if you continue it beyond 5 to 7 days, you can have rebound congestion. Xylometazoline is safe to use in pediatrics. If the child's nose is severely congested and it's causing acute otitis media or acute suppurative otitis media, you can consider xylometazoline at 0.5%. If you all have any other questions, you all can ask them. Yes, so even when you use the otoscope, basically you support the speculum. If you're using your right hand, you examine the right ear, and you can support the speculum and use the tip of your little finger resting on the patient's cheek, so that if they make any sudden movements, you don't injure the canal.
Does anybody have any other question? Okay, I think most of the questions have been already covered. The ones that have been asked earlier through the link, I think most of them are already covered. And Dr. Tia also added a few more slides about the questions that were not covered in the session later. So I think then we'll wrap up the class.
Yeah. Okay.
Okay. Uh, I'd like to thank Dr. Queenie and Dr. Tia for taking time off their busy schedule, especially Dr. Tia. She had an emergency OT. She ran back home just to attend this class. So thank you so much. Also, we would be adding Dr. Queenie and Dr. Tia to the group. So if any questions come up, any cases come up, they can answer your questions and you can discuss it on the group as well.
Yeah, you can feel free to take down my number, especially if you're in a center and you have a sudden doubt, and you can call anytime. It's 9902380147.
I will put your contact on the group, and I'll add you also to the group. Yeah, so then it'll be easy for them.
Okay.
So thank you everybody. Before you all leave, we'll be putting up a feedback form. Please fill these forms. I think we look at the feedback form to see what y'all are, what y'all want from us, because there's no point in us doing something and which is not going to be useful for y'all. So please, you give us feedback. We are actually looking through the feedback and we're trying to modify the classes based on your feedback. So please do leave the feedback. And once again, thank you, Dr. Queenie. Thank you, Dr. Tia. Thank you.
Thank you,
Thank you to
guys.
everyone for joining this class. Have a nice Sunday.